In 1983, I was an intern at San Francisco General Hospital, where within a month I knew more about HIV, what later became known as HIV, than any doctor in the world. And since that time, I've continued to take care of patients. I will see patients tomorrow morning in the AIDS clinic. I used to serve on the Armed Forces HIV Monitoring Board. I served on the FDA Antiviral Advisory Committee when the second, third, fourth, and fifth HIV drugs were approved. I chaired the CDC's HIV Prevention Committee. I have seen in my professional career astounding progress that saves people's lives in the kind of way that you've talked about. Our foundation has as one of its 3 program areas Innovations for the Underserved, where we are dedicated to the principle that, as you heard from the first panel, the answer to this problem can't simply be finding someone to pay the bill for an overly expensive and inefficient system. We've got to innovate our way out of this. Health policy people tend to blame technology or intensity of technology for the rise in costs. And that's always bothered me because in every other industry, technology makes things cost less, not more. And so increasingly, I have come to the opinion that, as my son would say, you shouldn't hate the player, hate the game. It's not so much that the technology costs more, it's that our system, for a variety of reasons, including insurance and regulation and culture and lobbying and lots of things, tends to diffuse and take up and spread cost increasing, which is to say margin producing technology, and tends to retard, discourage, or often obliterate cost decreasing or disruptive technology. My own view is the industry has to do a little better job of trying to figure out what are the positive regulatory changes that are necessary. Clearly, an FDA paradigm from 30 years ago is no longer relevant, but I think you've heard some interesting examples of having kind of a more positive, creative reaction to a regulatory block that says, here's how we should do it.